So our patient here has a little bit of a tight orbit, as you can see, but one of the nice things about LensX is with a small patient interface, you can usually get into that without too much difficulty. Look right at that center ring of lights. Good job. Suction.
Holding. And then place.
Pushing the center button automatically centers the capsule and all the other parameters. You can adjust them manually if you want to a little bit. Everything looks good to me, but I'm going to bring that primary incision in just a little bit. Perform an OCT scan. One of the things that you want to pay attention to is making sure that the dock is flat and looking at how thick the cataract is. I'm amazed at the variability in cataract thickness. By moving this posteriorly, the magenta line touches the posterior capsule, and that's 500 microns away from the posterior capsule, ensuring that you get a nice even break of the cataract. And then when you look at the corneal incisions, one thing to note that's really important is that the incisions with this LensX laser are really, really good. You can see these arcuates right here. And the incisions open easily, and probably more importantly, they seal easily, and we can show you that in the operating room. So the capsulotomy takes about 4 seconds, give or take, and it's essentially complete every single time. Then we go into the new fragmentation pattern with the 2.23 software. There's two horizontal planes that are created too to make it so it's not long French fries, but shorter cubes. The arcuates are made, the primary incision is made and is really dialed in now, and then the paracentesis is made, and we're back to the operating room. Good job, dear. Get you back there in just a second, okay? So you can see that the capsulotomy has been created and that it looks like it's free floating. There's some air bubbles from the cavitation bubbles that are created from the laser when we perform the surgery. There's some arcuate incisions here. I usually like to treat astigmatism up to about a diopter and a half with arcuate incisions. Then one of the things I want you to pay attention real closely to is the quality of these incisions, both the arcuate incisions, the paracentesis, and the main incision. So as you go in here, you can see how easily that incision opens up. That wasn't pre-opened, that's just the femtosecond laser. Put a little bit of intracameral lidocaine in the eye, a bit of viscoelastic, and one of the things that you want to do is try to move your viscoelastic cannula on top of the capsule, because those free-floating capsules could get blown into the angle 180 degrees away. So now, pay real close attention here to how nicely this incision opens up. I don't use a special instrument, just my capsulotomy forceps. I close them, I dial the incision, and I'm in, and it's that easy. Then what I do is I take the capsulotomy forceps and I just test the capsule, make sure that it's free floating everywhere. It is. Pull that up and out of the eye, and capsulotomy is perfect, and it's done. Now hydrodissection, get underneath the anterior capsule and you'll see a typical fluid wave that goes back behind the cataract. The fragmentation pattern with the 2.23 software really hasn't changed my technique that much. It's just really lowered my phaco energy. So I go through my typical incision, I still go and have it on sculpt, but I basically don't use hardly any phaco energy. And this is actually quite a fairly dense lens. Remove that central groove and you'll see how nicely that cracks. Spin. Do the same thing. And one of the things that's really nice is how the lens stays together just about as much as you want it to and falls apart just about as much as you want it to. And so you can see here there's a little divide there, and you can see how nicely that cracks. I'll do it here without doing much for groove there or divide and conquer. I didn't divide any in that direction and it still cracks nicely. And you go into quadrant removal. Grab your first piece of cataract. Comes out like it wants to. And once you grab that, kind of off to the races. One of the things about the balance tip and the Centurion is that the pieces are really magnetic to the tip. They want to stay at the tip as we're removing cataract surgery, so you can stay in your safe iris plane, away from the cornea, away from the posterior capsule. Notice how stable the anterior chamber is throughout the procedure. This allows you to be nice and aggressive because you're not going to get trampolining from the posterior capsule. And whenever you're removing this last fragment, we're always paying attention to make sure that that posterior capsule doesn't want to come forward, and it doesn't come forward at all. That was a surprisingly dense cataract, but still takes very little phaco energy and fluid to remove that cataract efficiently. One comment that I've heard people say is that they feel like it's harder to remove cortex after having a laser cataract procedure. That might be true, but as you can see here, it's not hard to remove it. It's maybe just a little bit different, and sometimes you have to go more into the periphery. One of the things I like to do with the balance tip is you can see how there's that ridge right there in the center. I like to use that as a capsule retractor, especially for my subincisional cortex. That allows me nice access to that. And then the polymer tip is so soft and forgiving that you can be fairly aggressive polishing the posterior capsule. Alright. Just creating the arcuates with the femtosecond laser does relax the astigmatism to a degree, and some people prefer to open them after surgery. Some people prefer to open them at the time of surgery. Some people like to use some intraoperative diagnostics to determine if they're going to open it at the time of surgery or not. So there's a lot of things that can help us. Okay, BSS. Take a Hunkler or a Slade. I'll take a Slade. You can basically use almost any fine instrument to open up your arcuate incisions. We have a Slade spatula that we use to open up the paracentesis that I find works nicely, but a Sinskey hook works well too, and you can see how nice and easily those arcuates open. Wexel. The other thing that I want to point out is how nicely that incision seals. Even after manipulating the arcuates, there is no fluid through that incision, and you can tell that I wasn't overly aggressive in the stromal hydration. So the incisions with the LensX seal very, very, very nicely.